Hi, everyone. We're just about to get started. We're here for the cup of tea for our June event. So I'll give everyone 1 more minute and we'll be starting right on time. Okay, so I see it's exactly 8:30 and I'm going to get started. So as people come on in, they can just follow along. So first, before we get started, I have a quick announcement to make. We have the Retinoblastoma Research and You booklet, which is now available. And we're very proud of this accomplishment that we've made. It's a booklet, which is a guide to patient engagement and research for people affected by retinoblastoma. If I could please ask everyone to just mute their mics when they come in. Thank you. So you could find the digital version of this booklet on our social media, which I've listed here on the slide. You can pick up a hard copy at your next appointment at a retinoblastoma clinic. This is in Canada only. And if you do not have an upcoming appointment, a hard copy can be mailed to you. Just send me an email with your address to ivana.ristevski@sickkids.ca. And I would like to ask you to please share with all other retinoblastoma families that you know, so we could get this out and reach as many people as we can. Okay, here we are. The agenda for today, I will share some information with you about the cup of tea, a few housekeeping items, and then JQ will be sharing the article summary with you today, followed by a conversation with the group. Now, because we have only 30 minutes here today, we can continue this conversation on Twitter for the next 24 hours, where I say 24 hours just so everybody has some time to answer questions. So we will not be online the whole time, but within the period of 24 hours, we will try to get to your questions and comments. So our Twitter handle is at @RB_research, and you can use hashtag #CrabCupOfTea. That's hashtag CRRABCUPOFTEA. So this cup of tea, it's like a journal club. This is an event intended to bring the Canadian retinoblastoma community together for an informal discussion about a research article. This event is occurring quarterly throughout 2021. The first cup of tea was in June and is available on our YouTube channel. And I highly advise everyone to watch our first cup of tea. It was very informative and it had great presentations, but it also was a great introduction to how these summaries are created, and a good introduction on how to read a research article. So the discussions will center around articles which our CRAB members have created plain language summaries for. And for today's cup of tea, we will discuss global retinoblastoma treatment outcomes association with national income level. So the plain language summary of this article is available on our website, so you could read it. For housekeeping, I would ask everyone to put their view into speaker view. This way you'll be able to see the presentation and the person presenting at the same time. Also, I'd like to ask if we could use the raise hand function. This could look different on different versions of Zoom. Some could be under the participant icon and others could be under reactions, and others might just have the raise hand function in the Zoom toolbar. Okay, so our guests today are JQ, who's the author of the plain language summary. He's a retinoblastoma survivor living in Vancouver, BC. He was introduced to the Canadian Retinoblastoma Research Advisory Board, or CRAB, by his ophthalmologist and has participated in several activities and events, including the creation of the Retinoblastoma Research and You booklet. And assisting him with the summary was Dr. Ashwin Malapatna, who's a pediatric ophthalmologist in the retinoblastoma program at the Hospital for Sick Children. He practiced in India and Australia before joining the team at the Hospital for Sick Children. And Dr. Malapatna's research interests include staging, classification, and the early detection of retinoblastoma. So I'm going to pass it over to Jay to share his article summary. And during his presentation, he will have some questions for the audience and we can have some comments at that time. But I just because of our short time, I would like to ask everyone to keep their comments short and concise so we can hear everybody. Hi, Jay. I'm going to stop sharing and you can go ahead.
Awesome. Sounds good. Thanks, Ivana. I had an intro ready, but you did such a great job. I feel like I can skip it. That being said, I do have my tea, which is a green tea with kiwi in it. So that's, I hope you guys are all stacked and ready to go on that side. Why are we going to talk about global RB treatment outcomes? Well, I was born in Singapore, lost my left eye to cancer, RB, as you guys might imagine, as a baby, and then moved to Canada, as you can tell by my accent. And I guess when I saw the list of different options in terms of what articles I could pick, I thought, oh my gosh, Singapore is kind of like a well-developed country, as is Canada too. And I guess I was curious about how treatments differ. Do diagnoses differ apart as you go through different countries? And so that was really why I picked this article in the first place. And without further ado, let's jump in. So global RB treatment outcomes. And by the way, I'm losing my voice, so we'll see how far we can go before I tap out. I have a few definitions before we jump in, but I'm imagining a lot of you would be familiar with this. Rapid fire, unilateral, you have tumors in one eye. Bilateral, tumors were found in both eyes. Metastasis might be new. It was something I had no idea what that was as I dug in. Metastasis is when new tumors are formed.
Could I ask you to stop for a second? Because
yeah.
3 people and I were on a totally different link, because there was another link for this meeting sent by Kate Payton, and they're in another link. So let me just email them, and because they don't want to miss you, Jay.
Oh, okay. Yeah. Thank you for quarterbacking that, Brenda.
So I'm just going to forward this to them, but I don't even know if Laura's. Laura got, yeah, Sammy is there, and
so I told them all, and they are coming. They found the link.
You found it? Okay.
Oh,
good.
perfect.
Yeah,
Thanks, guys.
They are coming, all of them.
That's teamwork live in action. That's what I'll say to that. That's awesome. Thank you guys so much. So metastasis is when new tumors are formed in other areas of the body, but it's from the same cancer. And by the way, I'm not a doctor, so if I'm butchering any of these, please don't judge me. And by the way, feel free to correct me as well. Local treatment failure. This one was interesting too. So as we start to talk about like what different types of treatment there are, local treatment failure was when you try one way and it didn't work within a specific country for a specific patient, and so they decided to use a different type, a secondary enucleation, aka EBERT is what the acronym would be. I don't think anyone calls it EBERT. And then of course you have your oncologists and ophthalmologists, just in terms of terms that you guys might hear throughout this. Okay, what are we talking about today? One main question guided this entire article, and I am very conscious that the authors are in this call. So when it comes to RB, how do diagnosis, local treatment failure, and metastasis-related mortality differ across countries? One of the things to note is, as you look at national income levels, I'll show you where the participants were. It was quite significant. They took a look at 2,100, almost 2,200 participants across the world. This was 18 different RB centers, a shmoo of continents. And notably, I think this is important to call it right away, the types of income countries that they were looking at was high income, lower and upper middle income countries, but not lower income countries, if that makes sense. Lower income countries being like your third world countries. And I think that's important to note just because in terms of like the data, things do differ, but I thought that was something as a reader for me to be like, oh, I wonder why there wasn't any data available. That being said, it was quite longitudinal, as you can see by my footnote down below. They actually went from 2001 all the way to 2013. And that's something to think about too, right? It was over a course, a period of time. So you feel like you have a pretty good sense of how diagnoses and treatments occurred in the first like bit of the century. Which then led me to another question. Oh, I wonder how things are nowadays in 2021. But we'll get to that later. Okay, what did we find? Diagnosis. So as I look through all the numbers, there's a lot on this page, so maybe I'll start with the insight. As you might imagine, when diagnosis occurs is hugely critical. As my wife and I are thinking about family planning, a lot of them are saying, hey, as soon as the baby comes out, right, like that's when you need to start identifying whether the baby has a tumor or not. And one thing that struck me was within lower middle income countries, you're actually diagnosing twice the amount of time that it would take someone in a higher income country to get diagnosed, which for me was like, oh my gosh, that's horrible. So 24 months, that you're looking at about 2 years of age when these kids are getting diagnosed. And at that point, you know, what happens is it might be too late, right? Globe salvage, vision. As I went through family planning chats with some of you, actually, it was interesting because the consensus was like, hey, Jay, by the way, now things are a lot better. You know, people like don't tend to lose their eyes as much if it's caught early on. And so that was something that really stuck out to me. How I've structured this conversation is I'm not going to talk the entire time. I'm actually going to give you like a little piece of insight and then throw a few questions out on the board. One to Dr. Malapatna, who was involved with this, and then two to any clinicians or researchers in here so that it's more of a dialogue. Ashwin, Dr. Malapatna, would love some feedback here. Why do you think bilateral RB diagnoses are occurring so much later in lower middle income countries versus high income countries?
So first off, thanks, Jay. I think the summary that you had so far is fantastic, and you did a fantastic job of analyzing the paper in great depth. Straight to the question, this is potentially a very difficult question, and it's not answered by the data that's in the paper. You know, why are there really these bilaterals that are diagnosed later? This is a question that we can quite frequently ask ourselves. And my hypothesis there is that the healthcare system is so much more attuned to bilateral survivors of retinoblastoma in higher income countries, and therefore more knowledge, more infrastructure available to cater to that kind of an early diagnosis, which is not present in the low middle income countries. But that's again something that we can delve into with more future studies. I think this paper also lists out a whole bunch of things that they could look at in addition to the income level of a country. There could be so many other factors there, such as cultural factors, um, um, survival of bilaterals in general, and those sorts of things that could make a difference. We're not sure as yet, though.
Got it. And let me ask you this question. I'm actually going to shift the screen back to the data, if that's okay. But for this question, why is the median age for unilateral RB diagnosis, why is that so high, you know, compared to bilateral diagnoses, regardless of national income level? Any thoughts on that, Dr. Malapatna?
So that is a question that was answered in the 60s by a person called Knudsen. Knudsen realized statistically that unilateral retinoblastoma presents later than bilateral retinoblastoma when you look at the same population that's within the same income level, within the same health infrastructure. Unilateral is always present later. The reason for that is that children with bilateral retinoblastoma are genetically predisposed to get retinoblastoma. Therefore, they carry the mutation that will allow them to uh, um, get retinoblastoma in both the eyes. And that would mean that when you carry one mutation for well, you have two copies of the gene, and if one of them is already knocked out at birth, then the other one gets affected soon enough after, or sooner than, let's say, both copies getting affected one after the other. So for children with unilateral retinoblastoma, not all of them, but for most of the children with unilateral retinoblastoma, the body would have two normal RB1 genes, and the tumor would have two knocked out RB1 genes. So for the eye to go from two normal genes to two abnormal genes requires two hits. Whereas when a child is born with bilateral retinoblastoma, then there's already a predisposition to have retinoblastoma with one knockout, one gene already knocked out, and it takes less time to knock the second one out. Does that make sense?
Yes, yeah, that's great. And by the way, I know Q&A is going to start at the end of this. If you guys want to fire chat, like questions in the chat, feel free to do that too. But for the sake of time, want to open it up to any clinicians or researchers on the call. We have two questions out here. Feel free to tackle either of them. Number one, how do diagnostic timing differences across countries of different income levels? How does that compare to other diseases outside of RB, other infant cancers, that kind of thing? And then number two, are there any better metrics outside of national income level? So like if we remove that, are there other ways we should be looking at RB diagnoses, treatment, survival rates, etc.? Any thoughts?
I'd like to take the last question. Sorry, I'd like to take the last question, but only after others can have a go. Thanks.
I don't know any data that speaks to either question very well.
It's kind of a TBD kind of thing.
Well, I think they're very complex. That shows how complex it is and how diverse. And you know, I don't see data comparing retinoblastoma to other cancers. I don't know. Maybe Helen Damaris might know of something. And I don't know of other metrics. The easy one, of course, is national income levels, as this study was based on, because if I could just add, the reason that there's no low income countries here is that none of them had a national retinoblastoma, any retinoblastoma center of excellence to submit data from.
This is bringing a lot more questions to my mind too, about like, you know, what would it take to set up national retinoblastoma centers and that sort of thing too. But for sake of time, Dr. Malapatna.
Yeah, I think some things discussed in the paper were included other metrics, and some of those metrics proposed in the paper were socioeconomic health-related indicators that include annual per capita healthcare expenditure, physician and nurse ratio to the population, type of healthcare system present, and the presence of national retinoblastoma referral centers, which we mentioned, registries, and patient gender and religion. So I think the papers recognize that there could be many factors that we really can't measure in these places. But I think there really there are other metrics that are available in these areas, but perhaps it's not the importance of each family is separate from which healthcare background they come from. I have practiced in many countries, and it did occur to me that it didn't matter how much people would or families would earn, as much as it would matter how what they thought about the disease itself. The cultural barriers to having an eye removed was one of those reasons why children would go doctor shopping, and eventually the last institute who sees the child will be the one to treat it, which could perhaps then bias the population in that way to an older age group when they were actually diagnosed before but went shopping to different doctors before they started treatment.
Hmm. Yeah, that's really great insight. Helen, I noticed that you have your hand up.
Yes, I do. I just wanted to add that national income levels are sort of an easy way to compare countries. But as we all know, even within a country, you have these gradations of where you'd fall. And even if we look at Canada, we could probably look closely to see how well we do in terms of retinoblastoma outcomes or any other cancer outcomes. And you'd see differences, as Ashwin has pointed out, might be related to social factors, the distance you live from a hospital, access to insurance. And so while national income levels have been a good way to sort of look at the science, they might be biasing us to think about places as one thing when we know they're not. There's multiple layers. So I think we need to get better at that and look at these different categories to really understand what's happening. And then you'd have sort of a risk profile for each patient. The same way we look at genetic risk factors or other things that are sort of clinical, you could have a social risk factor that would tell you if a family or a patient was more likely or less likely to do well on treatment or survive or get better vision outcomes. But until we really study those things at those discrete levels, we won't know. And perhaps our focus on categorizing by countries loses some of that detail. So I think we have a ways to go still. Don't know exactly. And I think for your first question, how do the timing differences compare to diagnosing other infant cancers? So are you asking if other childhood cancers also have differences in timing of diagnosis depending on where you live in the world? I would think yes. In general, childhood cancers outcomes are poorer in low and middle income countries than in high income countries. But again, thinking to really rich families with access to optimal care, they're going to do better no matter where they live. And similarly, you could be a family with a lot of factors working against you, even in a country like Canada, and not do as well as other counterparts.
Yeah, that's very true. And you bring up a great point earlier about like digging into, with the RV centers that we do have, I wonder if it's possible to start to dig down into rural versus, urban or city data and see if there's a big difference there too.
Yeah, if I can just add, I put a note in the chat. I don't know if everybody in the call knows, but at Sick Kids, we've developed a resource, www.onerbw.org, and you can actually peruse all the hospitals we know of around the world and compare them based on what kind of treatments are available. You can see how many patients would be expected in each country, how many patients the hospitals report taking care of, and you can start to see the differences in RB care around the world.
Awesome. I did not know about that. So thank you for that link. I will definitely check that out. Moving ahead, love this conversation. Let's dig into the second piece, which was local treatment failure. So I think, to Helen, your point about how, of course, naturally, anecdotally, you're going to have higher and better and earlier, diagnoses in higher income countries than lower middle income countries. Very similarly, the same thing popped up for local treatment failure, right? The risk was much higher in lower middle income countries and UMICs as well. I was kind of thrown off, to be honest, by the fact that the risk was higher in an upper middle income country than a lower middle income country. But, throwing it out there to anyone who has any insight on that, Why is that the case? And then a second question would be to any survivors and patients. I don't know if we have anyone from outside of Canada, but if applicable, what's been your experience in RB treatment in other countries? I built these questions with no, we had a guess. We imagined some people might be on the call, that it might hit home or not. So we might move on too, if there's no comments.
Also, if
Could
you
I
think of
ask Efren
anything,
if he could speak, please? Efren? You could speak, perhaps. It's not here.
Sorry, someone cut out. Was that Brenda?
Yep, and Laura on the talk, and she's in South America. But maybe they aren't listening, or they've got their microphones muted and are trying to speak.
Okay.
if anyone thinks of any ideas or stories they'd like to share, they can also connect on Twitter afterwards for our offline conversation.
Sounds good. With 4 minutes left, let's, oh, Same, were you gonna say something? Sorry.
No, I was just going to say that in Egypt, I have worked in Egypt for Alexandria, Egypt for more than 10 years. So I think it's totally different in how we look into things here in Canada rather than other countries. In Egypt, it is usually there is no health insurance. The family dynamics is very important, where there are a lot of differences between males and females. And usually the males are the ones supporting the family, while on the contrary, the females are the ones that are taking care for the kids. So with the beginning of the treatment, you don't see the father anymore, and you see only the mother, and then the father disappears, and the mom has no money to treat the kid, and then you don't know. So it's another piece of treatment that is not present in Canada. You don't see that here in Canada. It's not an issue to think of. The social context and the financial burden are a lot to handle, and I think they affect the outcomes a lot. And I think me and Dr. Gali and Helen, we did a couple of papers from our cohort in Alexandria regarding the socioeconomic impacts and also with the absence of genetic testing, how the knowledge and the genetic counseling regarding the genetic basis of retinoblastoma would affect the second generation or the next sibling with retinoblastoma. So I think there are things that we don't think of. Not we don't think, but we don't face, and they affect in other countries.
Yeah.
Maybe
Yeah.
Laura also can give some insight about the situation in South America. We had a couple of conversations about that.
Yes, good night to everyone. I'm from Asunción, Paraguay. And it's really, really hard. Well, we don't have a retinoblastoma center. So it's very complicated because patients, I think the social economics counts. We don't have the proper equipment. Like there's no hospital that has an ultrasound or a red cam. So it's very hard to put in practice what you learn when you don't have the equipment or the possibility to do it. So everything is very, very difficult. We don't have we have a lot of private and public practice, but the public hospitals are really, really bad. Like we don't have, not like to get the drugs, to get melphalan, to get, it's very, very complicated. The treatment delays a lot, delays like months. So I think everything, like, I think that is very important for the outcome of the patient. You can give the treatment, you can give the appropriate treatment, and also the lack of knowledge, because we don't have as many cases. There are not like ophthalmologists trained specifically, because cases are not very much. So everything counts. And it's hard for me. And then when I remember when I was there in the fellowship, I go, oh my gosh, it's like it's very frustrating. So I say to the patient that has the opportunity to go outside, I encountered 2 patients that parents were capable, they have international health insurance. So I say, just go. If I were you, I would go, because I can offer you all the tools that we need. So it's complicated. I'm not sure if maybe Argentina is much better. Brazil is much better. But Paraguay, for example, we are not good. But I think it will change. Now we can do IAC, for example. So I think with time we can get better, but it's complicated. Yeah.
Yeah. There's so many different factors to kind of wrestle with, whether, you know, to Sami's point, the cultural aspect or the nuances, you know, by country. So
and the people get to the doctors late, you know, later. Yeah. Everything, they don't have the way to go to the hospital. They live far away. They like everything it counts.
Just noticing that we're right at time already. What I might do is I'll quickly share the last point, and then I do see, Michelle, your hand's up, so we'll then pass it on to you as well. Just to wrap up the last point, that was kind of like the big takeaway from this article, was metastasis-related mortality. I think this was, you know, to your point about it being bad, Laura, it just kind of, it shook me, to be honest, to the fact that you'd have a 10x or 9x factor of mortality, you know, just because you didn't have the right access to care was quite sobering, to be frank. But that was one of the outcomes of the article. And I guess I added this question of why is it lower within LMICs versus UMICs? Because, you know, I imagine that quality of care would hypothetically be better in a upper middle income country as opposed to a lower middle income country. So Dr. Malapatna, any thoughts on that? And then we'll pass it on to Michelle.
Well, that is a hard question. Why is there a difference between the lower middle income to upper middle incomes? I must say that this study has not captured every single patient in each of these countries, so it's hard to comment on that. It could be each of these institutes itself that are presenting their own data, so there could be a difference to what the entire country experiences. I think in upper middle income countries, you have more people accessing a hospital for care. But in lower middle income countries, perhaps there are children who never reach care. You know, there's a large discrepancy between the number of males and females who approach care in these countries, especially in the lower middle income ones. And some countries tend to favor male children for treatment. So, you know, in those types of selections and you know, those decisions that are not we can't assess through the data we have in these papers. I think the difference lies somewhere in there. You know, they may just be unseen in the lower middle incomes. I don't really believe that the death rate is lower. I just think that they may be unseen and may be higher.
Yeah, that's great insight.
Catherine, do you think it's possible that in the upper middle income countries, they're introducing new techniques and technologies, but maybe not getting the full follow through? or the full practice yet, to the point where some of the new introductions actually end up producing more troubles initially.
Well, in this particular paper, the low middle income countries were, the institutes that represented it were two from India, which pretty much had every form of treatment available to the children, and one from Jordan and one from Ghana. So I think that could be true, but it's not true across all of the institutes represented there. So I think there might be, there's potentially more to it there.
Thanks. Michelle, you have your hand up, and then we'll wrap up.
Yeah, sure. Sorry for going a bit over time, but yeah, I guess I can't really speak on my experience in the United States as a clinician, but I can speak on it as a patient. For some perspective, I'm a third generation bilateral RV survivor. I grew up in suburban upstate New York, treated at Sloan Kettering in New York City. I guess I had 2 points. The first one, I think that kind of shaped a lot of my RV experience was finding transportation, especially to New York City. Both of my parents are visually impaired and weren't able to drive a car. So things like that can easily present kind of a barrier to access to care, especially for RV families. The larger point, I think, though, was that, like, I think it could shape a lot of Americans' experience is the insurance piece. There is such a big private insurance component in the United States. I grew up on my father's private insurance, and fortunately it covered especially and gave like certain perks for going to centers of excellence for RV treatment and follow-up. But I think something that stuck out to me, especially from one RV World, I don't remember the person's name, unfortunately, but there was somebody from UCLA who had talked about sort of the main pillars of RV survivorship in the US, and one of them was keeping your insurance. And I think that definitely stuck out to me. I think that is such a like instrumental part to understanding the pathway to care for Americans, and it becomes normalized when you're within that system. And then I was like living in Canada now has given a bit of a different perspective on it. But I think, yeah, that plays such a big part into how people both get initial treatment and long-term follow-up, especially for people, like I know a lot of people who are on their parents' insurance in the US are only allowed to stay until they're 26 years old. And so given that, you know, long-term follow-up is such an important thing, especially for people who have the hereditary RV component, being able to have that kind of stability in insurance and being able to have that kind of long-term follow-up presents a pretty significant barrier to access to care, especially since, you know, if private insurance is so heavily tied to employment, we've seen, you know, job insecurity in times like COVID. I think it has such an impact on people that kind of becomes normalized when when that's your everyday, and that's, you know, the normal thing for living in the US. That makes sense.
Yeah, 100%. But thanks for that insight, Michelle. That's it's I think like you just totally brought to life and to color the difficulties too, and in terms of transportation and trying to get to treatment in the first place, along with the private versus public healthcare insurance nuances, right? We do have to wrap it up because I'm so over. But if anyone's curious, there's a second article that I also did a deep dive on that did a look in 2017 at just how things were in 2017 compared to the 10 years, and that's included on the link as well that Ivana sent out. Sweet.
Awesome.
Pass it back to Ivana.
Jay, thank you so much for the amazing presentation and for leading this great discussion. So I would like to ask anyone who has more to add and to share their stories with us online on Twitter at @RB_research. We can continue the discussion there and just sharing of stories and experiences, so we can continue there. And I will let the rest of the clinical team who has got to go to their tumor board meeting go ahead, and make sure to pick up your booklet when you're in the clinic, or email me to get your hard copy in the mail. Okay, thank you guys so much. Have a great evening.
Bye, everyone.